All right. Hello, everyone, and thank you for joining our webinar today from the Parkinson Association of the Rockies on Palliative Care is Not Hospice. We're here with Dr. Vaughan and Dr. Sumrall. Before we begin, I just have a few housekeeping items that I want to go through. First is that this webinar will be recorded and uploaded to our YouTube channel in case you have to go halfway through. We'll send out the link after. We will have time for questions and comments at the end, so if you'd please wait until then. There are two ways that you can ask a question. You can either type it into the question box and I will read it out, or you can raise your hand and I can call on you and then you can unmute yourselves. And then after this, please fill out the survey that'll appear on your page. It'll also be emailed to you. That'll help for future programming and things like that. From going on, I would like to now welcome our presenters, Dr. Vaughan and Dr. Sumrall.
Thank you so much. Thanks for having us. We'll each introduce ourselves. I'll start. My name is Christina Vaughan. I'm a neurologist, movement disorder specialist, and palliative care physician here at the University of Colorado Anschutz Medical Campus. And I'm in clinic, our neuropalliative clinic, during the week, and also work on the inpatient palliative care team. Malenna Sumrall is one of my close colleagues, and I'll let her introduce herself.
Hi, my name is Malenna Sumrall. My husband had Parkinson's disease with dementia, and that's kind of how I got connected with this clinic, the neuropalliative clinic. And that's what I'll talk about as we go through this process. I started volunteering in the clinic as just somebody who has been through a disease journey, and I've stayed connected with that clinic and other neuropalliative efforts since then. So,
thank you so much. So we'll get started. The title for this talk is Palliative Care is Not Hospice Care, and our goals are to distinguish the two because they're often confused or used synonymously, and there are some clear differences. So our overview is that we'll start off with two patient narratives that will help kind of set the stage for further discussion around what palliative care is and what it is not, and then a review of what hospice care is. And I think we'll probably have plenty of time at the end for comments and questions and so on, and be glad to answer those then. So we'll start with Malenna.
So I mentioned that my husband had Parkinson's disease with dementia. Today, what I want to do is just sort of share our disease journey with you and describe the types of palliative care that we were lucky enough to receive. My husband was diagnosed with Parkinson's in the year 2000. The only symptom he had at that time was just a slight tremor in one little finger. At that time, he had been a professor at the University of Alabama for 30 years. For the first few years of the disease, his symptoms did not interfere with his work or mine, and did not prevent us from living our lives as we always had. 6 years later, 6 years after diagnosis in 2006, however, he was diagnosed with mild cognitive impairment. The impairment was significant enough that I knew I needed to stop working and help him. So I retired early so that I could devote my time to his needs, both in his profession and at home. 3 years after that, in 2009, his diagnosis was revised to include the dementia. 1 year after that, he realized that the profession that he had loved for so many years was too much for him, that the cognitive decline was keeping him from doing his best. So he retired after 40 years from his faculty position. My husband's medical journey was quite varied, ranging from inadequate to superb. We started with a general neurologist whose knowledge of Parkinson's was very limited. We were not satisfied with him, but he was our only option. I want to give you a few examples of the reasons we were not very satisfied with this doctor. The first medication that he prescribed turned my husband into a zombie. He couldn't walk without support, and he could barely stay awake. It caused him to fall asleep while he was driving on the interstate, and he had a wreck that could have been tragic. Fortunately, he was not hurt. In spite of that, and in spite of us asking about that, there were no changes in his medication. He also prescribed a dopamine agonist at some point, and that made my husband very manic. So we talked about that, but again, the neurologist saw no need to change anything in his medications. Now, in spite of his unwillingness to change medications, when we talked about it and had concerns, he would do things like just change medications at random, and then without even seeing my husband in the clinic. And then he would just call us and tell us to go pick up something at the pharmacy. And that just never seemed quite right to me. He misdiagnosed REM behavior disorder. He insisted it was restless legs, and I knew it wasn't. And therefore, he prescribed the medication that you do for restless legs, but that made my husband worse. Obviously, it might be apparent that through all of this, he's not listening to either of us, and especially me. You know, if I tried to talk, he just tuned me out. So we were desperate to find better care. Finally, a movement disorder specialist did move into the state of Alabama, and we were able to get an appointment with him and started using him as our primary neurologist. With him, symptoms were accurately diagnosed finally, and therefore treated much better. Medications were much more appropriate. One of the problems was, though, that we could only get appointments with him every 18 months to 2 years because he was in such demand. And Parkinson's changes faster than that sometimes. This doctor was conducting a research study on dementia. He asked my husband to participate, which he did. And it was through that study that we got the diagnosis of dementia. The way we found out about that was that they sent us a letter. The letter simply said, "You have been diagnosed with dementia." There was no indication of what type it was or what we should expect. We had to absorb the shock of that diagnosis without a doctor present to help us understand. In 2014, 14 years after diagnosis, we moved to Colorado to be closer to a son who could help us. We had a referral to the neurology department at the University of Colorado, and by the luck of the draw, we were assigned to Dr. Benzie Kluger. Our first appointment with Dr. Kluger, he spent a lot of time collecting history and assessing my husband, but he was also assessing me. Dr. Kluger is the only doctor in 14 years of appointments who ever asked me how I was, and my response was overwhelmed. So based on my husband's condition and my need for help, Dr. Kluger recommended that future appointments be with the palliative care team. We had no idea what that meant, but it sounded wonderful, so we jumped at the chance. We were able to have 2 appointments with the palliative care team. In addition to Dr. Kluger's care and concern, I remember specifically how wonderfully Ryan, the spiritual counselor, and Carrie, the social worker, worked with us. By this time, my husband had lost his much-loved profession. He was quite physically disabled, and he no longer had the capacity to concentrate on any mental activity. So Ryan conversed with my husband at length about finding meaning in other ways, and he made great suggestions. I vividly remember Carrie, the social worker, talking with me about accessibility issues in our house. And when I confessed that we had a couple of steps that we had to negotiate, she very kindly but firmly told me I needed to get a ramp, which I did. She also provided me with a lot of recommendations for support services, which was really helpful since I was new to the area. During our second appointment with the palliative care team, it was decided that it was time for us to have in-home palliative care. My husband's had progressed to that point. Again, we had no idea what that was, but we were pleased that there was another level of care available. With the in-home palliative care, we had a nurse practitioner who came once a month. We also had access to a chaplain and a social worker if we wanted. The nurse spent a lot of time with both me and my husband during each visit, and she would review the criteria for hospice every time and explain why we didn't quite qualify. I always felt that she was trying her best to get us hospice services. Well, one of the advantages to being connected to this in-home palliative care was having 24/7 access to someone that I could call if I had questions or concerns. One day, when my husband was completely zoned out and didn't know who I was, this was the first time that had ever happened, I called the agency. Because of that episode, they decided that they were just going to call it a stroke and make us eligible for hospice care. So we were able to get the hospice care at that point, and it was a huge relief for me. We had a nurse and a personal care assistant who came several times a week, and again, access to the social worker and the chaplain. I could have had respite days if I wanted them, but that would have involved placing my husband someplace outside the home, and I knew that would be too hard for him, and it would have been hard for me to do that to him. So we never took advantage of that. Although my husband was declining steadily physically, his mental decline was variable. It was just that type of dementia. He could be his bright, wonderful, charming self one day and then completely out of it the next. One day, a day that seemed much like many others that we had had, the hospice nurse examined my husband and said I needed to get him in bed immediately. I said, what? I said, just yesterday he was fine. He was himself, laughing, talking, but she saw the signs. So I put him to bed and started giving him the hospice drugs as she told me to do. And by early the next morning, he was gone. Our journey could have been so much more difficult if it had not been for Dr. Kluger and his team. I would never have experienced being considered an important part of my husband's treatment, and we would not have had the comfort of palliative care at all levels. My experiences have convinced me that palliative care should be an option for anyone dealing with a neurologic disease, starting at diagnosis. When you first get that diagnosis, that's a really tough moment. And the disease has surprises all along the way that really can be addressed by palliative care. All these challenges are just, they get you by surprise. For the person living with a neurologic illness, there are all kinds of symptoms that develop and change over time, and you've got to face those challenges and deal with them. And with each of those changes, the care partner has to find a way to help the partner that they're caring for and to learn how to cope with it themselves. For both the person with the illness and the care partner, there are all kinds of emotions, including grief, guilt, and concern for the future. Having the support that palliative care provides as we face these challenges is invaluable. We were lucky to have it, and I highly recommend it to everyone. Thank you.
Thanks so much, Malenna, for sharing your story. And I think it's a wonderful stage to set as we get more into what palliative care is. But before we do that, I will share our second in the two narratives with you. And this is Adrian's story. Adrian was a research physician who came to North America on a research fellowship, first to Canada and then to New York. A very cerebral man, he saw his most valuable asset as his brain. He met his wife in a laboratory and they had 2 children. And at age 45, in 1985, he realized his arm wasn't swinging as he walked and the pen felt funny in his hand. He recognized the signs of Parkinson's and diagnosed himself, even when neurologists weren't initially willing to confirm this. He continued to work for many years, keeping his diagnosis a secret from his colleagues, which involved going to another city for his neurologic care. And eventually, nearly 20 years after the diagnosis, he developed some GI symptoms that resulted in severe cramping and extreme weight loss. Workup didn't reveal anything of note or anything fixable, and the future was even more uncertain what was going on. As such, he enrolled in hospice in 2002. The hospice medical director kept him in the program for nearly a year but it seemed he had plateaued in many ways. So hospice determined that they could not justify continuing care for him, and he graduated from hospice, which was a mixed blessing. It wasn't until 12 years later, in 2014, that he re-enrolled in hospice and died within a few weeks of that. For those 12 years between the two enrollments in hospice, the family hired around-the-clock caregivers, and he had 3 to 4 visits with the neurologist per year. It's always a big deal to go to the neurologist. He would get all dressed up. But when he got there, she maybe made minor changes to his medications and didn't do a whole lot else. She certainly didn't talk to his wife about how she was doing. And when his advanced Parkinson's led to really severe hallucinations and delusions, his wife became concerned for the safety of both of them in the home and felt compelled to speak to the neurologist about that. And the neurologist linked her to a social worker in the clinic whose advice to her was that she leave him. Certainly she didn't take this advice because it didn't make any sense in the context of their lives, and the social worker didn't know much about them at all. And so due to his paranoia, she went to court. She had to go to court to seek guardianship, which was a very painful, drawn-out process, but was successful. And the family felt very much alone for those 12 years in particular in between hospice enrollments, and really was always on alert, always in survival mode. But when hospice returned in 2014, there was much relief, with an emphasis on more aggressive symptom management, a real focus on comfort, not just for Adrian, but for the family, support for the family. And thanks to hospice care, Adrian died comfortably at home, which is what he wanted. So from these two stories, they have some similarities, both cerebral men, academic gentlemen. But from these two stories, you see how one had the benefit of palliative care coming alongside, both ending with deaths enrolled in hospice and benefiting from the hospice care, but different paths to getting there. So let's talk about the crux of the matter. What is palliative care? Well, imagine for a minute that there was a type of medical specialty called supportive care. Forget the word palliative, supportive care. And the goal of that supportive care team is simply to help people living with chronic or serious illness to do as well as possible for as long as possible. That's it. That's the whole goal. One might say that this is the goal of all medical providers, and that's true, but this is above and beyond the priority to help people live as well as possible, as long as possible in the face of a serious illness. The word palliative really is synonymous with supportive in this way. And you hear the word palliative more and more in the world, in media, particularly now, thankfully, in neurologic disease. You can see how these are some headlines: palliative care helpful for MS, for multiple sclerosis, for Parkinson's, for dementia. Even the Parkinson's Foundation sees the importance of palliative care involvement and has initiated a program across all centers of excellence in North America to implement palliative care practices in centers of excellence for people living with Parkinson's disease. So it's becoming more and more discussed and understood, and I think you're going to hear about it even more in the future. So let's actually define what it is in more detail. First of all, what it's not. It is not hospice. And to be honest, I'd rather define what it is first, but I'm going to stick with this. What it is not. Palliative care is not hospice. It's not comfort measures only. It's certainly not giving up. It's not doing nothing, far from it. It's not only for the imminently dying, nor is it only for patients who have cancer diagnoses. It's not only provided by a palliative care specialist. So these are things that it is absolutely not. It's also not something that you're on. You're not on palliative care. It's not something you go on. It's a medical team that comes alongside the care you're already getting or the care your loved one's already getting. But it's not something you're enrolled in the same way hospice is. Hospice is somewhat of a status change in what the goals are. Palliative care is not something that necessarily shifts what the goals are. And the last thing I'd say, which really gets under my skin, is when people say, well, it's not time yet for palliative care. They're not ready. And I would push back and say, it's always the right time for palliative care. It's, as you heard from Malenna, it's not something that's reserved for people at the end stages of their condition. In fact, the time of diagnosis is a very fine time to have some palliative care involvement, even just a little bit. So even colleagues of mine who in the hospital will be like, nope, not time yet, not time for palliative care. I really am curious to hear where they're coming from, because I think it stems from a misunderstanding of what palliative care is, and again, what it isn't. So what's in a name? The word palliative, people often say to me, why won't you change that? It's a scary word. It gets confused with hospice. And I like the word. I'm a purist. I like the word because it comes from the word palliare, which means simply to cloak. And I like that because this is a powerful visual, right? The idea of a cloak, another layer of support and care, that's it. That's what it's meant to be. So for me, that's why I like to keep the word around and use it. I would say that other centers across the country have changed to supportive care from palliative, and in some cases that results in more consults because people are less scared of the word, but I'm going to try and stick with it and use the word palliative because of what it means. So here's what it is. Again, it's a medical specialty focused on improving quality of life for people living with serious illness at any stage. And again, the approach to care is to help people live as well as possible, as long as possible. That's it. It's not more complicated than that. That's it. It's best provided with a team. And as you heard from Malenna, we try to maintain a team-based approach as much as we can. And this is an interdisciplinary team. These are multiple disciplines working together to come up with a cohesive plan. And at the center is the family and the patient. And we're trying to take stock of not just disease management, helping with symptoms, thinking certainly about the physical symptoms, but also the psychological, the social, the practical sides of living with Parkinson's, any existential or spiritual concerns people have, practical concerns, as I said, and any end-of-life worries. It's not uncommon for patients and families to say, tell me where we're going. What does this look like 5 years from now? We do our best. You know, it's still very hard to paint a very accurate picture, but we can attempt to lay out a roadmap. So discussions about the future, we don't shy away from those. In fact, we welcome them because it can help people today plan and often relieve some of their distress about the unknowns that may lie ahead. We try to shine a light on what might happen so that people can feel prepared if that's what they want to discuss. So a typical palliative care team tries to keep the patient and family at the center and includes a medical provider, a physician, a nurse practitioner, a physician assistant, someone with a background in palliative medicine. And then as you heard with Malenna's experience, she had Carrie Friedman as social worker, who also works for PAR, Chaplain Ryan, our spiritual counselor. And then at the time, Malenna was working with our nurse, Wendy. We now have a new nurse, Laura. But together, we all try to come at any sources of challenge or struggle that a patient and family is having from our different backgrounds to see how we can be helpful. Because I certainly don't have the skill set Ryan has, for example, to provide spiritual support. So that's where, you know, he is integral on the team, for example. So where can you find palliative care? Well, it certainly depends on your region or part of the country that you're in. You know, we're lucky here in Colorado because we have very strong palliative care programs, particularly in the community. So palliative care can be community-based. As you heard from Malenna and Ray's story, they ultimately had community-based palliative care coming into the home. They don't come all that often. In general, they come perhaps every 4 weeks. It really depends. But as you heard, they're available by phone, and it includes a team, like Malenna described. There's also hospital-based palliative care, the inpatient team. When somebody is admitted to the hospital for a serious illness, palliative care is often consulted to provide that extra layer of support to discuss goals of care and advanced care planning. So certainly in a hospital, palliative care teams are found. In fact, that's probably the most common environment where you'd be finding a palliative care team. And then clinic-based palliative care, as you heard about our clinic through Malenna's eyes, that's another option. The University of Colorado also has a palliative care clinic that's dedicated to non-neurologic conditions such as cancer or end-stage organ diseases. And we will soon be integrating with that clinic and expanding. But the point is to say that outpatient palliative care clinics can be found around the country as well. So one of the things that palliative care teams like to really focus on and feel particularly skillful at are trying to help with medical decision making. So what I mean by that is, say somebody with Parkinson's is faced with an orthopedic surgeon offering surgery and discussing, hey, you know, I can do this and fix this misalignment in your spine, for example, or this orthopedic issue in your knee or hip, and I think you should do it. Well, that may be a really good decision, or it may not be. And we like to try and get involved, knowing the patient and family, knowing the Parkinson's and what the disease is like, and help families and patients navigate that sort of decision. Is it the right idea? I don't know, but let's talk about it. Let's talk about the risks, benefits, burdens, and also what's most important to the patient and family. And the best way that we do this is to have a goals of care conversation. In fact, any meeting with us or with the palliative care team really, when done well, is spent talking to the patient and family and learning about who they are. What makes you tick? What's most important? What are your values? What are your hopes? What are you hoping for? How do you identify? How do you see yourself? And what's your life story? What's a bit of the narrative? What should we know about you? We don't want to just focus on the diagnosis and the symptoms and the medicines. We want to actually understand what life is like now and what it used to be like, so that we can understand how different things might be. From that place of trying to get a sense of what's most important, we can do a better job at moving forward and making medical recommendations and finding out or coming up with a plan of care, which is a negotiation of goals of care, understanding what's most important, and then linking that up to what's medically possible and coming up with some medical options. So once we hear from someone this narrative and understand their goals, then we're better positioned to think about, does this orthopedic surgery make sense? What are the risks? Again, risks, benefits, burdens. What's the most likely scenario if we have this surgery? What's the worst case scenario? And what's the best case scenario? Helping guide patients and families in this way. That's another tool or another skill that palliative care teams really try to help with. We can help make decisions about whether or not to have focused ultrasound or deep brain stimulation surgery, trying to, again, weigh what's most important with what's possible, and with the expectations of what would a surgery like that actually accomplish? What is it possible that it will accomplish, and what might it not accomplish? And from that, we can also make recommendations about advanced care planning, right? Thinking about what you would or wouldn't want done medically if you got really sick in the future with anything, a heart condition or anything else, knowing your values and who you are, your story, and what your diagnosis is can help us help you think about advanced care plans for the future. So that is one of the many ways palliative care can be helpful in the face of any chronic serious illness, getting goals of care and trying to make medical recommendations on how to move forward. So when is palliative care appropriate? Well, you've heard both of us say a couple of times now that at the time of diagnosis is a fine time to meet palliative care, just to understand what a team does, what they can help with down the road, however long or short the road is. If people lose their ability to drive and driving is no longer safe and possible, that could be an opportunity to meet with the palliative care team to talk not just about the coping of that loss, but also about strategies to continue to be active and get out into the world, participate in classes, boxing and so forth, and think about other transportation options with the help of a social worker. When patients, if they get to a point of needing help, say dressing or with other activities of daily living, this is another helpful time to connect with a palliative care team. Again, not just to talk about coping and what it's like to be in this new place of needing assistance, but how to get the right kind of assistance in home, how to connect with community-based home health care, caregivers, and so forth. Once again, social work might be particularly helpful in this area. And then if decline starts to accelerate, as Malenna described, there was a period of time in Ray's history where things just started to get worse more quickly. For some people that happens, for others it doesn't. It's so variable, but that might be another time for palliative care to check in perhaps more frequently with the family, with the patient, and see what are we missing? What else can be helpful here? Because you don't know what you don't know until you shine a light on what's possible. And then at the time of death and after that, for bereavement, that's where hospice can be particularly helpful. So if we really drill down and think about the course of Parkinson's disease, here's a timeline, so to speak, and it's however long it is, decades, years, whatever the timeline is. But on the far left, you see DX, that's the abbreviation for diagnosis. As I've said, diagnosis would be a fine time for palliative care to check in, to have a goals of care conversation, as I described, to understand the narrative, who the person, the family, who they are, to establish a decision maker. This is particularly important in the state of Colorado. This is a funny state, and not everybody realizes that if any one of us winds up in the emergency room by ourselves and we're fuzzy-headed or we can't speak for ourselves about medical decision making, the state of Colorado does not default to your spouse, your next of kin. Instead, this is an all-interested party state where we are obligated on the medical team to round up anyone we can in your life, your family, your friends, and have an all-interested parties meeting where together that group of assorted people comes up with a consensus on who should be the spokesperson. You can see how that's an epic waste of time, potentially, and it can all be avoided if you simply document who would be your medical decision maker. You don't need an attorney to document this. This is just a medical durable power of attorney form here in Colorado. So having that discussion with palliative care up front, having at the time of diagnosis is a reasonable time to do it if you haven't done it already. Then moving forward in the course of Parkinson's disease, we can be helpful, as you've heard, with spiritual support, care coordination, social work support, talking about psychosocial needs, and potentially some complex symptom management. Maybe we can help even more with things like constipation or even pain, which can happen in Parkinson's. And then moving forward in time again, time point number 3 might be an opportunity to talk about the road ahead with the family, maybe to help have a family meeting, what's possible in the future, what can we plan now, thinking about a timeline or a roadmap for the future. Again, some symptom management could be helpful, talking about legacy work, thinking, you know, we're not in a crisis now, what can we do now that you'd want to have available to your family down the road later on. So talking through topics like that could be helpful. Time point number 4, again, maybe more family meetings, maybe introducing hospice as something that could be helpful down the road. Because the last thing we want is for suddenly there to be a crisis and nobody knows what our options are. What can we do now? You know, and knowing about what some possible things that could be helpful are earlier might help ease the transition whenever that comes down the road. Filling out a MOST form, medical orders for scope of treatment. That's the form we use in Colorado. That dictates what someone would or wouldn't want done medically when it comes to things like CPR or artificial nutrition. Filling out one of those documents can be extremely helpful and protect people from having medical interventions that perhaps they wouldn't want. Again, moving forward in time to time point number 5, closer to the end of life, potentially very advanced disease, however many years that is later, palliative care could be helpful in making care transitions if we need to change the living arrangements. Again, some more symptom management. And then when it's clear, or as clear as it can be, that somebody has possibly a 6-month or less prognosis, then they're appropriate for hospice care. And hospice is a medical team that comes to wherever the patient is. They provide equipment, teaching, meaning education to the family on signs and how to treat symptoms at home or wherever they are. They provide medications, nursing support, home aides, volunteers, and you have 24-hour access to them by telephone, and a nurse answers the phone. This is the standard for all hospice agencies on what they're supposed to provide. And once somebody has passed away, hospice provides 13 months of counseling resources, support groups, bereavement support for anyone, family and friends. And that's important to know too. People don't often realize that, you know, hospice is there, they're there, the patient dies, hospice is gone. Sometimes that can add to the feeling of loss, but in fact, hospice is glad to stay involved in a bereavement support capacity. So this is a timeline, again, could be many, many years, but these are potential time points along the trajectory where palliative care might be of particular help, coming alongside your normal neurologic care. So when we compare and contrast palliative care and hospice, they have a lot of similarities, meaning that they both focus on the whole person. Again, trying to think about the psychosocial, the emotional, the physical aspects of living with a condition like Parkinson's. Palliative care, as you've heard now many times, is appropriate at any stage, whereas hospice is strictly for people who are thought to have a life expectancy of 6 months or less. That is really hard in medicine in general to make these predictions, but it's particularly hard in neurologic conditions. Sometimes it's helpful to use the surprise question, which is, would I be surprised if this person were to die in the next 6 months naturally as a result of their condition? That doesn't necessarily mean that you're predicting that they will die, but if they're at a stage where you wouldn't be surprised if they were to die, then I would make the case that hospice is appropriate if they're in that sort of situation. Absolutely, people do not have to be at the very end of life, days to weeks to live, to be enrolled in hospice, because then they've missed out on potentially many months of the extra support. Palliative care can be combined with disease-modifying treatment. Unfortunately, in Parkinson's, we don't yet really have disease-modifying treatments, but we will soon, I'm sure of it. But in the meantime, other conditions like cancer or maybe MS that have some disease-modifying treatment, palliative care can come alongside just the same. But when people are on hospice care, unless they're a veteran in the VA, disease-modifying treatments are not offered when people are also enrolled in hospice, because the focus is on comfort and the goals have changed. The goals are to focus on symptom management, not on disease modification at that stage. Again, palliative care can be provided at a hospital, a clinic, or at home in a facility, and the team comes to the patient always in a hospice situation, wherever the patient is, at home, in a facility. And certain hospitals in certain parts of the country have inpatient hospice situations. So hospice comes to the patient. But again, the overlap between them is really the approach, which is to think about a person as a whole person in the context of their life, taking into account the physical, emotional, spiritual, and psychosocial aspects of living with a chronic serious disease. So my one slide on more details with respect to hospice is to better define it. It's a specialized type of care for those facing a life-limiting illness, for their families, their caregivers, addressing the patient's, again, physical, emotional, social, spiritual needs, but not focusing exclusively on the patient, trying to support the family as well. Medicare pays for hospice. This is a Medicare benefit, and that includes, as I said, the equipment, the medication, the staff coming to the patient's bedside, and so forth. In order to be eligible for hospice, as I said, somebody needs to have a prognosis of 6 months or less. I lean on the surprise question. Would I be surprised if they were to die in the next 6 months? And therefore, that's considered a terminal illness, a terminal diagnosis. Curative measures, as I said, disease-modifying treatments are not provided when somebody's enrolled in hospice, except in certain circumstances like being through the VA system. Someone needs to be enrolled in Medicare A. And there are local coverage determinations. In other words, real specific symptoms that hospices are looking for certain diseases, certain cancers, certain heart diseases, and so on, liver disease. The hospice is looking for certain markers to suggest how severe those diseases are in that person, and they can lean on those determinations, those criteria, to make a case for hospice eligibility. There really isn't a whole list of criteria for Parkinson's disease, so we do the best we can. And it's best, if you're working with a provider who knows you well and knows your history and knows how rapidly things may have been changing recently, to make a case for hospice enrollment. It's really based on the physician's or the medical provider's clinical judgment. It's not an exact science. So as you saw in Adrian's case, he enrolled in hospice in 2002 and graduated because hospice felt he wasn't eligible at that point. And then it wasn't until over 10 years later that he re-enrolled. Hospice came out of the UK, or at least we give credit for it coming out of the UK, from a woman named Dame Cicely Saunders. who was a nurse and then a physician. The word hospice, I like the roots of words, comes from hospitality, and it can be traced back to medieval times when it's referred to as a place of shelter and rest for the weary or for ill travelers on a long journey. I love that. I think it's appropriate, a good word to use for what it's being used for. Yeah, that's all I'll say about that. So that's all we've prepared formally today. Hopefully you have a better sense of what palliative care is, what it's not, the overlap between it and hospice, but the clear distinction between the two really lying in the prognosis piece, palliative care being, available for anyone at any stage of a chronic life-limiting disease, but hospice being reserved for people thought to be at the last 6 months of life. So palliative care is not hospice. Both are forms of supportive care. And I sound like a broken record, I guess, but palliative care is appropriate at any stage of Parkinson's disease. So very glad for your attention. And we have, I think, plenty of time for any questions, comments, etc. Thank you so much for inviting us.
All right, wonderful. Well, we do have a few questions. The first one had raised their hand, Margaret Gomez. I'm going to unmute you, and then if you'd like to ask your question.
Hi, sorry, I'm totally unprepared. How do you, I missed part of the program. How do you get palliative care? Where do you look?
That's a great question. How do you get palliative care? So usually what happens is you work with your main provider, your main doctor or medical provider, who's either a primary care doctor or a neurologist, and make the suggestion, hey, I think we would benefit from care, and that provider referral to either an outpatient or community-based palliative care program that comes to you, or connect to a clinic if one exists near you. And then if someone's in the hospital, palliative care teams are living in the hospital essentially and can be consulted that way. And I'm curious, Malenna, I can't remember, how did you guys get palliative care, community-based palliative care?
That was just the recommendation from Dr. Kluger and the team. It was just that my husband had advanced to the stage where they felt it was getting hard to bring him into the clinic, for one thing. And so it made more sense to have the people come to us and then stay in touch with Dr. Kluger.
I guess, and perhaps something else, is there a cost for this?
It should be covered by insurance. Malenna, what was your experience?
I'm sure it was. I have no idea. Yeah, because I certainly didn't have to pay out of pocket. So it was either Medicare or something that took over. Yeah. For the in-home palliative care you're talking about, or in the clinic.
Either one, I guess.
Yeah. Okay. Yeah. The insurance covered that.
Okay.
Right.
Thank you.
Wonderful. And then we have one written question. I was recently told by a local hospice in Boulder that hospice care includes life expectancy of 1 year now. Has that changed?
Not that I'm aware of. But if they're providing it in that way, that's great. I think, hospices get a per diem fee from Medicare for each patient, and it's the same amount of money. And they sort of divvy it up to different patients according to their needs. And some use more than that, some use less than that. And, hospices are driven to care for people that continue to show progression towards end of life. And sometimes, as you saw in Adrian's story, they can keep people on hospice for quite a while. I don't know that they go in accepting people that have a year or less left, but if that's news for the older hospice, that's good to know. I don't know that to be true.
Great. And then Sandy, I will unmute you if you'd like to ask your question. Sandy, you are self-muted, so you will have to click the little microphone icon to unmute yourself.
Oh, no, there. Okay. My husband has dementia, and I was contacted, through Dr. Vaughan for doing palliative care. And I thought, well, we're not ready yet. But how different is treating dementia patient from a Parkinson's patient?
It's a good question. Sometimes they overlap so that some people with Parkinson's eventually go on to develop dementia, as you heard in Ray's story.
Yes.
Other times there are so many different kinds of dementia. Not every, people with dementia don't necessarily have Parkinson's disease. Both are neurodegenerative, so changing, unfortunately, worsening over time. And so there are some commonalities, such as talking about the future, talking about prognosis, talking about safety, talking about support for the family, trying to minimize or eliminate caregiver burden or burnout, and caregiver fatigue. All of these can be very big deals, big topics in both someone with dementia without Parkinson's or somebody with Parkinson's at whatever stage. Symptoms can overlap as well, whether it's fatigue, whether it's trouble carrying out activities of daily living. People with dementia can have pain, just like Parkinson's patients can have physical pain. And sometimes it's hard for people with communication trouble, whether it's from dementia or trouble speaking for other reasons, to describe their pain or for us to even know that they're in pain. So having this approach to being thoughtful about symptoms and trying to understand what symptoms may be invisible to us when someone with, say, dementia isn't able to tell us is also important. So I think there are a lot of common palliative care struggles to be addressed in somebody in a family living with someone with dementia as well as with Parkinson's at whatever stage. Malenna, you have anything to add on that?
No, well, I think, there are lots of things that just from my support group that I've seen, the paranoia that sometimes happens in both cases, Parkinson's or a dementia of some type. But again, the whole idea that you're struggling with this disease and you've got this anticipatory grief that's working on you, the guilt, the worry about, the patient's worried about being a burden on the care partner, and the care partner's worried about, staying healthy enough to, all those things are part of either of these diseases.
Thank you.
All right, Greg, if you would like to ask your question now, I believe you will have to hook up your microphone to be able to ask the question. And then Greg, if you'd also like to type out your question, you're also welcome to do that. Just a reminder, you guys can raise your hands or you can type them in the question icon and then I can read them aloud. All right, Greg, we're going to move to Kirk. And Kirk, if you would like to ask your question, I believe you will also have to click your microphone icon to verbally ask your question. Okay, in the meantime, I will ask, someone had typed in, do you see palliative care differently for someone living alone?
No, if anything, I think might have a bigger role in some cases. Sometimes people living alone feel more isolated, don't have the additional support or help. And palliative care teams, through potentially the social worker, could consider helping link that person to extra support in the community, whether it's a support group, an exercise class, whatever it is that makes sense for that person. But I think it's equally, if not more important. Malenna, anything to add there?
Yeah, and I think the palliative care team can make an effort to try to include family members that may not be close by, so that, you know, you're kind of helping everybody understand what's going on.
All right, and Greg, we can try you again. If you would like to unmute yourself and ask the question, or feel free to type it in again. All right, we will move to another written question. Is it better to join a palliative care group with expertise in PD, or better to go with a local care group?
A good question. I think joining palliative care regardless is better than not, I would say, just to have that extra thoughtfulness about what the lived experience is and how to try to make it better. So whether or not someone has expertise in Parkinson's disease, people with training in palliative care will be able to help guide and have goals of care conversations and so on. I think when it comes to prognosis or symptom management, if you want expert care, which is disease specific, then certainly having a palliative care team that is familiar and has experience with the diagnosis would be particularly useful. But if you're leaning on palliative care more for goals of care and psychosocial supports and that sort of thing, then perhaps the Parkinson's expertise might be less important. But I guess I would say my bias is to work with a palliative group that has palliative expertise. And if they also have Parkinson's expertise, that's a bonus, rather than somebody that's maybe got an interest in palliative care. And you know, if you're going for palliative care and you want palliative care, make sure that you're actually going to people that have experience and training in palliative care. Obviously, I'm biased too, because our team is really experienced with Parkinson's specifically, as well as other neurodegenerative diseases, but it's not essential, I would say. Malenna, what are your thoughts?
So when I started volunteering in the clinic, well, let me back up. When we were patients at the clinic, then, you know, I just thought, okay, each of these 4 people that are part of the team comes in to see us one right after another. And that's the way it is. When I started volunteering there, I could see how it worked. And the doctor, whether it was Dr. Kluger or Dr. Vaughan, would probably go in and see the patient first, find out the medical concerns, but they're also, because they're trained in Parkinson's and palliative care, they're able to sort of read between the lines and see, you know, what are these symptoms telling us? And so they can pick up on things that need to be addressed. And then what would happen after the doctor visited the patient, they would come back into this room where all the team is gathered and sit around and talk about what they learned, and then make decisions about, okay, I think this person really could use some time with Ryan, the spiritual counselor. Carrie, the social worker, can help with this and that and the other, but you don't necessarily have to see the whole team. You see the people that are needed at that time. And having the person that understood the Parkinson's and was able to pick up on maybe sometimes, you know, the signals that not nonverbal signals really made a difference. There's so many symptoms that are part of Parkinson's that are way beyond the motor symptoms, and being able to understand that, understanding that grief is part of it, understanding that pain is, paranoia, hallucinations. Those are the kinds of things that they understand and they can help you with.
All right, great. And then I see, Pat, you had typed in your question. You're also raising your hand, so I will unmute you, and then you can unmute yourself and ask your question.
Understand and they can help you with.
All right, great. And then I see, Pat, you had typed in your question. You're also, I'm not sure. I will just ask that question. So yes, this webinar will be available in the future. It will be uploaded to our YouTube channel, and a link will be sent out to everyone that registered for this event. And then one other question is, what is the best way to bring up palliative care with your MDS?
That's a great question. Malenna, do you have any thoughts?
Well, for me, it just sort of happened naturally, thank goodness. But don't be afraid. Don't be afraid to ask and explain maybe why you want it. I don't know. What do you think, Dr. Vaughan?
Yeah, I think that sometimes movement disorders specialists may not know that it's an option, or maybe focused on so many other things that zooming out and thinking about the big picture, there's no time for that in a visit. And so saying, you know, I'd like to bring on another medical specialty into our team. You know, I'd like us to broaden our team to include palliative care, at least a one-time visit, and see how they might be helpful. Because as I always say, we don't know what we don't know. So until you try it and check it out, it's hard to know, is it going to be helpful, and how helpful is it going to be? So bringing that up to your MDS and saying, you know, why don't we just check this out? I'd like to, you know, and the idea really is to come alongside, not to take over care necessarily, just to come alongside and be part of the team and collaborate. That's the ideal.
Great. And Tom, I see that your hand is raised. I do see that you are not hooked up to your microphone yet, so you will have to do that quickly just by clicking the microphone icon. Tom had also stated in the questions that he wanted to remind everyone not to wait to bring it up to your MDS, to bring palliative care up in the conversation. He had to ask the question for his wife. I believe he's referring to his MDS was good about referring, but he had never brought it up initially.
Thanks, Tom.
I believe those are all the questions that we have lined up for right now. We have about 2 more minutes on this webinar, so if anyone else has any questions, please feel free to raise your hand or write them. We have one question of what is MDS?
Movement disorders specialist. That's a neurologist, usually a neurologist, sometimes a physical medicine and rehab physician, but they've done a fellowship specifically in movement disorders, which not only includes Parkinson's disease, but other diseases like atypical Parkinsonisms and Lewy body disease and tremors and Huntington's disease. So again, movement disorders specialist.
Wonderful. Nothing else seems to be coming through. Is there anything else either of you would like to mention?
Just thank you for having us and giving us the chance to explain what this wonderful treatment method is. Everybody needs to know about it and needs to, you know, hopefully can find it for themselves.
Yeah.
Appreciate the opportunity. Thanks to PAR.
Yes, well, thank you so much for doing this. This was a wonderful webinar. And I will let y'all know when it's uploaded to our YouTube. All right, thank you so much.
Thank you. Bye.